this forum is kind of designed to be very interactive. It's not sponsored by RxSight. This is just a couple of ODs who want to talk about cases a little bit more off-label that we can kind of push the limits a little bit, and that's specifically what tonight's agenda is kind of about. We want to talk about difficult cases that maybe you look back at the label and it says don't do an LAL with these cases. We want to talk about what we did, why we did it, how we did it, and then I want to sort of gather opinions from everybody else. What could we have done differently? So I'd encourage you to turn your camera on if you don't mind, or if no big deal, but just speak up and join the crew here. So I'll talk about my case first, and then we can kind of go and I just want to share an interesting guy that we actually just did not long ago. Okay, can you guys see my screen?
Yep.
Awesome, cool. So I don't know if y'all have done a refractive lens exchange patient, non-cataract. We've done a number of them. This was probably one of the more unique ones just based on his prescription. So he's a 30-year-old. He is literally he's the taste tester for Molson Coors, which is the coolest job ever. Love my job, but that would be a cooler one. And he's a little bit amblyopic. So if you look at his prescription up here in the top right, he's +6 with a ton of cylinder in each eye. And 20/30 best corrected in the right eye and 20/20 in the left. And he came in, he wanted LASIK, right? Everybody comes into our office wanting LASIK or ICL. And both of those are definitely out of the question for him. So we ended up doing an LAL, surprise, surprise. The interesting thing, I would like to gather your guys' opinion. Does anybody do AKs with cases like this? Anybody?
Yes, we encourage them to try to shave down some of that still if possible.
Yeah. Anybody else?
A 350 SIL, I'm still staying away from it. We use the LI laser and shave down a little bit, but so I want to see how y'all did this.
Yeah, would you guys not do an LAL in this case? What would you do instead? That's an honest question. What would you rather do?
Yeah, that's the problem, is I'm not sure what to do for this 30-year-old. So
sure,
I would, my brain goes 350 SIL. I don't know that we can do that. And then my screen's a little blocked as far as. So yeah, I want to see how this went. Okay.
Yeah. Well, it went well. Surprise. They wouldn't present it. So we did do AKs. We did femtosecond laser assisted cataract surgery. And we put AKs in. So the tricky part, especially with an amblio, I wasn't sure, and I counseled him before that reading glasses will 100% be necessary, because I wasn't sure with an amblyopic eye if we're going to get any sort of usable near vision out of the right eye. And we started that. So here on the 16th, just about almost a month ago exactly, this is his refraction down here. So he's -1/4 +75. Very good outcome, actually. The AK did a lot in his right eye. The left eye, there's still definitely some cylinder to get out, but that's well within the range of the LAL. And that was the idea. The theory and kind of what we're seeing, that if you can debulk the cylinder on the cornea, you have more workable flexibility with the LAL, and you have more room to move in the myopic direction if you can get some of that astigmatism taken care of beforehand. And so I think we kind of lucked into having more of the astigmatism gone in the right eye, because that's inevitably going to be his near set eye. So we initially targeted plano. I didn't like the idea of inducing negative spherical aberration right away in the amblyopic eye. Would you guys agree with that strategy here?
Yeah.
Okay. Yeah, that's what I was thinking. Let's not do that. Let's not induce any sort of optical noise into the system any more than we have to. He came back a week later, and he's doing very good. We overshot him on the right eye a little bit. Left eye is cut down in half. He's still a little myopic with some cylinder. He's thrilled. He thought we were done. Oh no, we can get better than that. I didn't put on his uncorrected acuity, but it was 20/20 minus, I think, in the left eye. It was actually surprisingly good. We ended up the third treatment on his left eye. was a plano target, and then we actually initially left his -50 there just to see if he adapted, and he found that, yeah, there's a perceivable difference. The myopic target in his right eye was usable, and he wanted more. And I always give trial frames. I always let them walk around a little bit, especially with him, with somebody who's naturally going to have a higher near demand and a lot more, he's going to put more miles on this than our average cataract patient. I let him walk around for a little bit. I think I even threw a contact lens on his right eye just in the office to see if he really appreciated it. And he was a resounding, yeah, I can definitely get some usable reading vision. So we did his final target at -1.25 and then left his left eye ready to lock. And so we ended up, I didn't put on the final, I haven't seen him post-op yet, but this is where we ended up. I assume he's doing fine. So we ended up very comfortable J3, which is not excellent, but it's definitely not bad. It's usable. He could see his phone, he could see his computer, especially at the office, and really good distance vision. So I guess final lesson is AKs can be done, and they can be very helpful in extending the range out, even in an amblio. Yeah. Does anybody have any questions or comments?
I'm really impressed with how much you got out with the AK with the femtosecond laser.
Yeah.
I'm not always seeing that much. That's why I hesitated on the left eye, even. So
I was very surprised. So we got, even the left eye, so we went from 3.9 down to 2 was a huge surprise to me. So yeah, normally I would agree. I don't usually see that much. I usually, when we use it, it's, we use it a lot, but it's maybe a diopter.
right.
It's not that much.
I think of a diopter. That's why I'm like, wow.
Yeah. So I was surprised at how much we got out of it. That was definitely an outlier. And so we kind of fell into it. But even my thought is that this is really with the rule of astigmatism. And if you have any residual with the rule of astigmatism, that's going to work in his favor. You're going to have extra depth of focus, especially in that right eye. And I talked to him about it. He's a smart kid, and he kind of understood. He's a microbiologist. He took physics and stuff in college. He definitely knew what I was saying. And he understood that leaving some astigmatism is not a bad thing, not necessarily a bad thing, especially in his right eye. So
For a patient like this, you typically allow a little more time to let the arcuate incisions kind of relax before you start treatments, or do you still do the 17 to 24 days?
That's a good question. I'd be interested to hear what you guys do. We usually, we use our 1 to 2 week follow-up as sort of a benchmark refraction, and then we look at the numbers at their 3-week visit. And so with him, I think we proceeded with a treatment at week 3 because the numbers were very close to the same. But I could have been convinced to wait. What would you guys do?
I like to wait just a little bit. Just because we've seen regression like 3 to 5 months post lock-in. If they like seem fine at lock-in and then they come back and some of it creeps back in. So I just want to make sure, like Jessica said, that it's completely relaxed before we start anything.
Would you wait? Like, how long would you wait, Jenny?
About 4 to 6 weeks total. And then, yeah, and you'd be surprised because you'd think that patients would be kind of like annoyed. But if you just explain, you're like, we can, I give them the option. We could start now, like the regular protocol, but this is what we've seen in the past. And do you want to see well for 6 months or do you want to see well for the rest of your life? And when they see it that way, it's like, oh, well, I can wait a couple more weeks just to make sure we have those stable refractions in there.
Mm-hmm. Yeah, I with him, he had a big trip planned. And again, the idea that it was with the rule, I was comfortable with that. And he was like, well, can we get done? And yeah, we can. And I made it clear to him that, yeah, we have a little bit of this left over. The numbers might not be 0, but we're not going for 0. We're going for your functional vision. So this is up to you. And he was cool with it, but he wanted to get done.
Yeah, they always have those trips planned. You're like, come on, people.
Yeah.
I have sent people on cruises with those glasses on.
Yes.
Right.
Go have a good time. Because they always have a trip plan.
Yes.
Yeah, I think this is a really good case though, because I've never thought of combining that with the capability of just the light adjustable lens and what it can correct for astigmatism too. So I'm going to definitely have to consider that. Nick, that was a great case.
Yeah, I mean, we use it a lot. We like to, at least market to our patients that we have literally any procedure for any prescription that you could have, which is true, especially the hyperopic. So I guess big lesson, don't forget your LAL for RLE patients, especially high astigmats.
Yeah. And Ken, you mentioned earlier you didn't know like if you could treat that amount. So we have treated up to 350 a few times now. And then RxSight has said that they've treated up to 4 to 5. But again, if you can get some AKs in there, that would be better. But technically they've treated 4 to 5 diopters with the incisions.
Nice. Okay. That's good to know. I was shying away when I hit those levels, like 350, I've been shying away, but that opens up a whole new world.
Yeah. And don't get discouraged if that, at their second follow-up, they still have usually only get like half of the sill each time. And then the last one, you'll have a fourth treatment maybe, and then finally be at plano.
Cool.
That high of astigmatism too is kind of low hanging fruit. Those patients are usually super happy.
Yes.
Even if
that's true. That's true. Those folks tend to, they've dealt with a lot already. So they
rotating lenses.
Yeah. Yeah. So like I said, I mean, even if there's residual, it's usable residual most of the time. We've had a couple of patients even earlier, like way back 2020 when we started doing this, we weren't doing limbal relaxing incisions or AKs at all. I remember we had a couple that were like in the 4 range and we did it. They were cataracts, but they were left over with a diopter or 2. But I remember this one was in tears. She was so happy. Well, the numbers don't quite, the anal side of my brain didn't like the numbers not being 0. But she was happy. That's all that matters.
I always like 20 happy.
Yeah. Anybody else who wants to go next?
I can go next. If I can make I'm not very good at sharing screens, so we'll see if I can do this. All right. I'm like the least tech person around.
It's just a button.
I'm trying. Hold on. What does this look? Wait a minute. There we go.
There we go.
Yeah, we see it.
Do you see it? All right. So talk about RLEs with LALs. I had a 54-year-old RLE patient and starts out pretty great. Let's see if I can't see what you guys are seeing, to tell you the truth. What did I do?
We see it.
Yeah, we see your screen.
Okay. Initial refraction at the first treatment, he started out a little bit plus here, and we did our first treatment. We targeted -75 in the right and plano in the left. Okay. Now this was, I believe, a regular LAL. This was not LAL plus. This was before we had the plus. So, we're talking pretty normal here. Comes back. Wait a minute. 1 week later, after the first treatment, 20/20 J1 plus. This is his refraction. It's actually -125. I'm like, oh, okay. But patient literally goes, I love this. Can we lock in? And I'm going, hey, absolutely. So we did our first lock-in, right? And he comes back a week later, freaking out because his distance is blurry. And lo and behold, I refract a minus a half. I'm like, well, no. So I treated the surface, I'm like, hey, maybe we dry it out, because I've seen, after a lock-in, it's an intense light, I'll get some SPK and some things like that. So we treated the surface and we saw him again. And we did this a couple of times and refraction was unchanged. So in the left eye, after the first lock-in, we decided to make an adjustment on the left eye to get it back to plano. Because I'm like, I checked it a few times, it was consistent. So we do the adjustment after lock-in, first lock-in, and left eye, he comes back and he's happy. He's like, that was it. And he comes back, he's back to +1/4, -1/4, 160. Same thing as at the first lock-in now, which I thought was kind of weird. So my question to everybody, what do you guys think? Why did I get the minus 50? Because I don't know. I scratched my head. I'm like, okay, the guy's happy. Why did I get that minus 50 a few weeks in a row? And did the refraction really change? Did the treatment after lock-in work? Or was that minus 50 a red herring? Because he ended up back exactly where he was at the first lock-in versus Plano or something like that. So I just wanted to know what people thought about this, because you know, all y'all do this even more than I do, and I thought it was fascinating. I did this one other time real early on, and I had to do a treatment. I just couldn't find that patient's case to put them together. And you know, we did a treatment after lock-in 1, and he was happy. We were able to do lock-in 2. So
I have one question, and then I did just have a call with Ron a couple weeks ago because I complained about this, and because I'm like, well, patients always say everything's mucked up after their first refraction or first lock-in. What's really going on? And he's like, well, actually, there is some negative, there is a negative prescription that is induced during the lock-in. So then that makes me worry. I'm like, should we be treating that or not? And they didn't really give us an answer of, because it should only be a quarter. So my question is, have you seen this patient back? Because that I've done it once, but then half the time I leave them because I'm like, well, he says that the lock-in 2 is going to undo that negative correction that was induced during lock-in 1.
I thought it was
co-managed
the first
patient.
lock-in. Don't they induce a quarter of plus, or am I backwards on that for the lock-in number 1?
I thought it was +2, but then in the call, he's like, it induces minus. And that's where I was confused, because I was like, oh, okay.
Yeah, I always thought it was plus.
Because that's what I thought too, but he said minus. Because I was asking because I like to lock in if the patient is Plano before I do any treatments. Because I'm like, why do you really want us to do the Plano treatment? And he's because it can induce myopia if you just go straight to lock in. I'm like,
Interesting.
oh. Mm-hmm.
Okay.
I've seen this before too, and every time it always reversed with the second lock-in. So I'm just like, I will just tell a patient, keep treating the dry eye more aggressively, increase your artificial tears. And sometimes we see a little decline with the first lock-in, but it should come back to what it was before we started the lock-in process once you're done with your second lock-in.
Okay, because I haven't seen this a lot. That's why I wanted to bring it out, because I'm like, you guys sound like you've dealt with this more than I have, and that's fascinating. So I don't even think I was learning that it induces a little minus to begin with.
I don't think they don't talk about it a lot, but I think I started complaining about it. And they're like, well, technically this is, and they don't say it because they figure, well, just tell them that their vision is going to be blurry during lock-in 1. They know it's going to get fixed with lock-in 2. And so then they don't really go into the detail of why.
Mm-hmm.
So I don't think you're wrong in saying you've never really heard it before.
Okay, yeah, I really hadn't. And so, you know, that's good to know. That makes me feel a little better, because I'm like, was this real?
Yeah. So what do you think?
But
Where do you sit, Ken? Do you think that the second or the treatment after the first lock-in actually did something?
I don't think it did.
Okay.
But because he went back exactly like you guys are saying, it was exactly the refraction before the first lock-in. You know, because I shot for Plano. Why did he come out plus a quarter, minus a quarter? I don't know. I thought it was strange, and that's why I wanted to bring it up, because I want to understand this more. So if it happens again, I'm a little more comfortable.
I have experienced some wonky numbers after lock-in number 1, but I usually just power through and get number 2. So once they're at lock-in number 2, I whatever the numbers are, we're just going to go treat it, and then things go back.
Mm-hmm.
And I'm comfortable doing that because that's what I've seen, but it always catches my attention.
Yeah.
I think this patient was more distressed, and that's why I kind of waited and I did a treatment, even if it was placebo effect, because this particular patient was really distressed about it, because he absolutely was in love with his vision at that first lock-in. And so I didn't know.
I think you did the right thing, because you know what? The patient left happy. And
Yeah.
that's because if you didn't do it, he would have been like, I paid all this money. They didn't give me what I wanted. You gave him what he wanted. He was happy. And yeah, that's all he's going to remember. So that, I think that was perfect.
Yeah, you did the right thing. Doesn't matter how you got there, you got there.
Thanks. Yeah, but I'm glad to hear it, because I was really not thinking that treatment did anything, but the fact that you guys have seen that drift a little bit, you don't see it that often, but most of the folks, yeah. Anyway, that's great. So.
I think did somebody have a question? Oh, you're on mute.
So I've got someone, I've done one lock-in and she's not happy now. So I'm going to have to do that 4th treatment. But then you just do one more lock-in when you don't have to do 2 lock-ins, just do the final lock-in once I get her. So
Right.
she drifted just a little bit.
Myopic?
Yeah, just a little bit, just a core, but I don't know that she really likes being offset. So I've told her I could bring her back. I'm letting her try contact first. So I was going to bring her back, probably back to, I think she's about a 1 1/4 right now. And I'm going to probably bring her back to about a 1/2. And so she's trying to contact lens. I'm hoping I can do that. If not, we're going to have to do PRK on top of her. So I don't know. Any thoughts on that?
You can try. I mean, if it's a 4th treatment, you might not get all that.
That's
I've
what
done,
I've heard.
yeah, I've had that scenario before where I've had a patient who, they say they want to be offset or myopic in one eye, and yeah, this is great, this is great, this is great, and then all of a sudden they change their mind and
Yeah.
we're forced to do a 4th treatment. And I've gotten, I think, up to a 1/2.
Hey everyone. Sorry, I haven't seen you guys in a while. I think I missed the last meeting or two. I just have a really quick question. This is just more about a question regarding how are you guys actually counseling these type of patients? So I had this one patient, so he's basically plano for distance, the other eye he's -150. Follow the dominance and everything, the adjustments. I think I got him down in like 1 or 2 adjustments, but he's still complaining about that he's still seeing a bit of a blur for distance. So, but he's reading 2015, right? So I think it's his non-dominant eye that's kind of like having its effect while he's seeing straight ahead. And then when he's reading, he's like, yeah, it's not crisp, but I'm like, can you read the 2020 line? And he's totally fine with that. Right. So I feel like I figured that like this is mainly related to his brain still trying to like adapt to the blended vision. So my question is, how do you guys how are you kind of like counseling such patients, or what are you saying to such patients? Like, especially when they ask, well, I mean, like, how long is it going to take for me? Or like, what do you guys usually say to such patients?
So most of the time when I have patients, almost always when they're 2015, but they say that it's blurry, it's always tear film. I mean, once you get that good, or even 2010, I've had a couple of patients who are reading the 2010 line. Any problem with tear film or any less than perfect tear film is going to cause 2015, and that's like just so detrimental to these patients sometimes. I tell them that I kind of counsel them, especially after the lock-in, that we got to make sure that we keep the tiers optimal. I guess I don't know where were you going with the. I guess I don't know. I kind of lost my train of thought. Tear film is important. That was my point.
So like it's not so much tears that this person is having like issues with, because like he's not really complaining about like if his vision is kind of going like in and out. He's just like there's just like almost like a haze in his vision. He's like it's clear, sorry, like it's blurry, but he's still able to see everything. So
have you tried dialing back that non-dominant eye just by like 50? I mean, not dialing it back, giving him a contact lens with just a little bit, hold it with a loose lens first and in the office, and just say, do you feel that lift just a little bit? If he does, then you can trial it with a contact, but most of the time this is a little too much for both eyes. If you dial it back a little bit, you're not going to lose much, if any, of the reading that you've already induced with the treatments. and he'll feel more balanced. But how much time have you given him so far to neuroadapt?
I think he's had about 2 weeks in total, right? Like about for now. I still have, I mean, like I still have room to kind of like bring him back, right? Like a little bit for the non-dominant eye. But I was like, you know what? Just keep using your lubricating drops. I'll see you in a month. Like, let's see what happens.
Yes.
Right. I'm like, I don't want to touch this because your numbers are perfect. Like he's seeing plano and minus 150. I'm like, I can always kind of dial it back. And I'm like, you know, worst case scenario, let's say like if we do a lock-in and it's still not Relic is doing, sorry, like, and you're still having this issue, I'm like, maybe I can give you like a plano with a minus 75 glasses for you to kind of get used to that. And then once you get used to that vision, then just remove your glasses and then try getting used to the plano with the minus 150 that's built in. So I was like, maybe we can do that. But I'm like, you know what? I'll just see you in a month. Right. So yeah, so I was just wondering, like, what are your strategies for, or if you've had those type of patients, or like, what do you guys usually say to those patients?
Yeah.
Oh.
Go ahead.
Oh, hi everybody. I'm Anne. This is my first time in this group and it's really helpful, but I have an exact same scenario going on as your patient. And it's definitely the blur or the fog he's describing as the monovision because it totally goes away when he closes one eye. And we started out having him plano and maybe minus 75. And he just really, really wanted more near. So now he's at 1.25, but he can't handle the difference. But really, like 80% of his day on the computer, he's very, very happy with his plano minus 1.25. He's just complaining about it in very specific situations, like if he has to drive a few hours. And so he just wears it. So he didn't want to lose the extra near that we gave him. But I just have him put in an Acuvue Oasis Max multifocal contact in his minus 1.25 eye that he just wears maybe like twice a week for a few hours when he does these longer drives. And he can still see near with it because it's a multifocal. So for him, we really, really agonized over, should we try to reverse some of that extra minus? But ultimately he wanted it, but it just wasn't perfect in every situation. And he's like 2 months past surgery. I don't know if he's going to neuroadapt too much more, but he seems happy with that compromise. He didn't really want to lose that extra magnification in the non-dominant eye.
What power Oasis did you prescribe? The whole 125?
I think I started with a minus 1 mid and his distance wasn't as clear. Like, I guess when he wants that non-dominant eye corrected at distance, he wants it really clear. So with a minus 1.25, which is this exact refraction with a mid add, he's 20/20 and J2. I mean, pretty good at near. So he just wears that for certain situations.
Nice.
Counseling patients, I mean, the way you phrase it is not necessarily staying out of glasses 100% of the time, but staying out of some need of correction for like 80 to 90% of the time. So whether that's a pair of reading glasses or a contact lens for those scenarios, I think as long as they understand that up front, expectations are key, then that's easy. And they, you know, I've got plenty of patients who they wear driving glasses, you know, truck drivers, for instance, where they want to have plano and then minus 1 or whatever. And we just give them a light pair of glasses that they throw on when they're driving trucks.
Yeah, there's a lot of, I love what you guys have done here and what you've talked about. You know, I have an anesthesiologist that, man, when he was in the OR, we had to have him, you know, plano and like 125 or else he couldn't work in the OR. But he and he was fine driving home from work and everything, but he'd go to his kids' soccer games and it drove him crazy. And we tried the neuroadaptation thing. And he finally, I tried a little contact lens on him and that worked. And then he finally just on his own came to the realization, he's like, you know what? It's only at my kids' soccer games. I think I can deal with that. Because it was the lights in the stadium and stuff like that. So, you know, I tell patients, you know, on paper, you're doing great. And I like this. We got to get your brain to like it too. And so first thing I do is let's go a month. so the first thing is what you did, Dr. Sullivan, is let them try it longer. And then you can play if you want to do anything, pull it back. Just so the whole group knows, I have LAL pluses in my eyes. I'm 6 weeks out and I'm doing great. But I played a little bit I was playing 075 and then I pulled it back just to see what would that do if I pulled it back to a quarter or something. Am I going to lose my reading? And I didn't. Now I put it back a little because I could, I put it back. But if you need to pull it back even a little just to get his brain to adapt it, you can do that, and he's not going to lose much reading. So I think these are all fantastic ideas, and you kind of have to feel your patient out, but let them know they're doing okay. And I always tell them, hey, this isn't a conscious thing. This is your brain doing this. So, you can't will this to happen. So let's give it some time. So the first thing you did by having them, I'll see you in a month. That's great. And then your patient that was a few months out, Dr. Madden, and you came up with that and they liked that. This is brilliance to me. So.
Yeah, no, I mean, like that multifocal lens idea, I think that's a really good idea. Like I never thought of that, to actually kind of hold them back in for the distance and still have a bit of an ad. But then again, I mean, like that patient is only just wearing it, as you said, just like a couple of times a week, but they just don't have it on them like all day, every day. That's not bad. That's actually a really good idea as well.
We had a question that do we offer LAL to dry patients and with bruising? I do with both. We have severe dry eye patients that have it. We just have to do good dry management with them, and we have full-on severe macular degeneration patients with this lens as well.
Yeah, we've done it with people getting active injections.
Mm-hmm.
They do fine. Key thing there, though, with that is don't induce the added spherical aberration. So that means right out of the gate, plano target both eyes. You don't want to add any more optical noise to their system, especially with dry eye or AMD. So just make sure you're starting them at a plano target and then going in the myopic direction if they can handle it.
Moderate to severe ERMs too, kind of stay away from that SA.
If you have a patient that is pretty like hyperopic, like right from this right from the jump. So let's say a plus 250 with a -1 cell, and just on the machine itself, and let's say like that's their non-dominant eye. So like I really can't bring them. No, I think what is this patient? I think this patient was even more so. Like, I mean, like I wasn't even, so I couldn't even bring them down to plano because their refraction right from the jump was quite like hyperopic. Then the machine itself said, are you sure you want to do like a hyperopic spherical equivalent? Right. So what do you guys usually do for something like that? Because the warning from the machine, I was like, wait, do I really want to? I don't know what I want to do here. Any strategies with that?
I go full. Go ahead, Jen.
Well, I was gonna say we bypass that warning and just say, "Yep, we want to do it."
Yeah.
Oh, so you don't bypass it.
Yes.
Gotcha. Okay.
Check your math.
Yeah, it's just
yeah.
I think there's a max amount that you can technically like treat per adjustment too. So it's just saying like what you're typing in is exceeding what is considered the max per adjustment. So they just want to confirm that that's what you want to do. But I'm the same way as Jenny, where I just go confirm.
Was that just a huge refractive surprise?
Yeah, I would say like, I mean, like, I don't think like they definitely did not aim for this patient to be, plus 250 like hypero. I think this is just a matter of like lens positioning post-surgery. All right. So so I was just like, okay, like I think they ended up being like plus 250 with like minus 175 cell. So I was like, man, there's a lot to really work over here to get this patient down to plano.
Good thing they had the LAL.
Yeah.
somebody asked if, they had a patient with 350 still, and then the message popped up. So then you cut it down to 2. Next time I would just leave the refraction how it is. Keep the 350 there. You want the LAL to treat as much of that as possible. So if you just put the 2, then it kind of throws everything off. So if you can keep, even though you get that message, it's okay to just leave your full refraction as EMR.
I have an example of a case we did not long ago. It was a guy, train wreck, terrible ectasia. He ended up with, he knew it was going to be a train wreck from the get-go. And we were like, well, an LAL is probably the best we can do because we can at least have some refractive control. He had like 6 diopters of cylinder preoperatively on his cornea. He ended up with, once we got down to the treatments, he was like 450. And so the LDD doesn't let you treat or even try to treat above 4. So what I did was cut the cyl down to the 4 diopter threshold and then maintain spherical equivalency. So you're at least training the most. And he ended up happy, actually, but he's still going to wear sclerals, which he knew he was going to have to anyways. So I could have presented that case, but it was just not as sexy.
That's good to know, though, that 4 is the cutoff, because then you keep trying to bypass when you're at 450. You're like, what's going on? That trick's not working. But
yeah, you got to cut the sphere. You just got to keep spherical equivalency. So you got to do a little math.
So were you able to bring that 4 cell down to like Plano?
No, not even close. We got it down. I think we ended up getting into, the numbers might be wrong, but we treated probably about 2 diopters of cylinder, which was the expectation. But it's just highly irregular, very, very irregular cylinder. His topographies were just a complete rainbow.
No.
So yeah, all part of the expected. He was happy. He is functional without his glasses, but he needs sclerals. At least he can see the alarm clock in the middle of the night now. That was kind of his goal.
all right, so patients with CME that arise in the middle of treatments. Yes, we've encountered that, and usually you'll send it back to the surgeon or the retinal specialist, and then they just stop treatments until the CME is cleared, and then you're good to go again.
Yep.
Make sure they are compliant with utilizing those RxSight glasses while they are outside or in a car or whatever your office protocol is, but definitely when they're outside, because that active shield is there, but it only lasts for a specific amount of time.
Yeah, we've done that too. We'll see him back in 2 weeks. If the CME goes away quick, great, right back on track. But if it doesn't, then you gotta wait till it's gone.
Yep. Depending on the severity of the CME is how often we'll follow up. If it's just trace or very, very mild, back in 2 weeks. If it's pretty significant, then and we'll treat. But if it's pretty significant, then back to our retinal specialist. But if it's mild, we'll just treat with like pred and ketorolac, and then I'll add extra artificial tears too, just because the ketorolac can kind of beat up the surface of the eyes too.
That's pretty much what we do. And once it's cleared, then we just resume treatment.
Mm-hmm.
That happened to one of my patients as well, and she's a cardiologist, and she's had the CME issue in her retina from before as well. So she's like, oh yeah, like I've done this before. So I'm like, well, it's happening to you again. She's like, yeah. So I sent her over to retina. They did one like anti VEGF injection. CME went down to 0, and then we basically resumed our adjustment afterwards.
Was she a diabetic?
No, she wasn't a diabetic. She just had like histories of random CME from before.
Yeah, we usually try to avoid. I don't send patients with CME to retina right away. Usually I do Durezol, ketorolac. Typically, if it's a pretty mild to moderate case, it'll respond quick. Our surgeon will do posterior subtenon Kenalog in office, and that usually kicks it right away. We always try to avoid anti-VEGF, just intravitreal vitreal injections, especially with this.
Can you guys go through your recent and past experience with the LAL Plus?
Me? All of us?
Yep. Because Nick, your practice was involved with one of the launching studies. So what did you guys?
So we've been doing it since early last year. It is the real deal. I mean, RxSight is now finally starting to, it's out there now. You can use it. It's commercially available. It definitely does add a bump in reading. And it kind of exactly as advertised. You're not needing to sacrifice as much distance out of the non-dominant eye. So most of my patients are maybe -1 and they're fully functional up close. So you're usually, I mean, we can definitely cut down the treatments. I'm usually locking in more at lock-in or at treatment number 4 instead of number 5. A lot of times I was playing with that near eye a little bit more, but most of my patients are much more just tolerant. They're retaining depth perception a lot better. They don't feel as anti. So not that it was really a problem to begin with the LAL if you're targeting it correctly. But even if I've had a couple of patients where we shoot like -1.25, -150, they're still very comfortable at distance. So the defocus curve is broadened, and it's very comfortable. So yeah, it's taking up probably 90% of our LAL patients at this point. The only ones we really don't think about it with is somebody with a really highly aberrated cornea, RK, or that LASIK ectasia patient I just talked about. We wouldn't have put an LAL plus in. What about you guys, Ken? I mean, Ken, you're the one who has it in your eyes.
I have them in, and it is the real deal. I mean, I had near vision the day after surgery.
Wow.
And the regular LAL patients don't usually have that to that degree. And we just this week, we did a little analysis. They did a little analysis for us with our LAL plus versus our regular LALs. And it's actually, we're averaging 1 less adjustment per patient before lock-in with the plus. So it's getting patients there faster and with less, less adjustments and less time. So it is the deal, like Nick says.
Do you feel like you've lost any contrast sensitivity or glare and halos at night?
I deliberately had to go drive at night just to see. And no, I don't have any glare and halos. I didn't lose any contrast sensitivity at all. I was previously wearing multifocal contacts, and I think I got a little bump from what I had with those. My distance is definitely better because I can get 20/15 in my multifocal contacts. My distance was 20/20. So no, I didn't lose any contrast at all. Here's the funny thing though. I'm not particularly dry, but I know the days I'm dry now. I tell patients I don't feel dry, but I can see dry because it will affect the quality of the vision. And you're just like, hey, I was good a few hours ago and this is just not as sharp, and treat that surface. I am now on, a dry eye regimen.
So that goes to Nick's point of saying, like anybody that's able to read that 20/15, but it's kind of blurry, dry eye. Hit that
There's
hard.
only one way to go. Once you get 20/15 or better, you're only going down.
Yeah.
Yeah.
You're not going to get higher than that.
That's my thing that always cracks me up when patients say, like, can we make it any better? And I'm like, you're seeing the smallest that you can on the chart. So sometimes they just like to hear that too, like just to the reassurance that you're seeing the smallest that you can, the distance, and the smallest you can up close sometimes. And they're 20/15 J1 plus. I'm like, any better, you'd be an eagle.
You're doing better than 95% of the world's population. That's
You're better than me. So I've got the luxury of a -1/4, -75. And like I'm 20/20 minus or so, but like I literally 20/15, I can't read that. Not from here without glasses on.
So is anybody putting plugs in right away?
I don't do it routinely. I've done it, I mean, a couple of times, but
I will use them, but not right away. It depends on the patient. If they're particularly, like a Sjogren's patient or something, yeah, I'm going to plug them because it's a production issue. But that's something I save for something where nothing else is working.
Okay.
In terms of the LAL plus, I think we're going to be getting them, so that we haven't gotten them yet in Canada. We're probably going to get them in the next month or so. Like, what's your best advice in terms of basically like approaching them? Like, should I just be doing my same regular like approach to, you know, like one eye for, well, like obviously one eye for distance, the other eye for reading, but is there anything like was there like one major change that you've noticed between the regular like LAL versus the plus?
I don't think there's any difference. We don't approach it any differently. I would agree with Ken. I mean, we're getting there faster. So my general regimen is my first treatment at about -75. As long as I am comfortable that they're going to tolerate it, which almost all of them do. And then if we need more from there, it's a big if, not everybody does, we'll go to -1.25. And usually that's where we're done.
And
I
then-
don't think I've ever gone past that with a plus, maybe once or twice, but not often.
Yeah, I
The
don't
surgeon
know.
just needs to know there's a different A constant too, because if they don't have the new A constant, then you need to tell them to target a -50 instead of Plano. Or else the patient's not gonna, they're not going to experience that bump in the reading then.
And we
Say
use the
that
same A
again?
constant. We don't change our A constant for it. It's the same, but
But
we're
then if you change it to the new one, because they have a new one, so then, okay.
Mhm.
Because then you don't
We-
have to change it. If you use the same one, if they use the same one that was for regular LAL,
Mhm.
then their target should be a -50 instead of Plano.
Yeah, I think they've optimized it and they're recommending, especially new users, to change to the new A constant.
Yeah.
We haven't. We're just comfortable with the old one and we know how to
And
kind
then so he probably just targets a -50 himself, like when he's
of
selecting.
-1/4. I'm not sure exactly, but yeah.
So the surgeon is targeting about a -0.5 on some of these patients, because my
Well, it
surgeon,
depends on which A constant they're using. If they've optimized to the, when did they start using the LAL?
January 23. And I can't get him to do, to aim that near eye for like a -50. They're coming out plus, and I have to take them down.
You still want them. So however you get to about Plano, that's kind of where you want to get. So however your
Mhm.
surgeon gets there, whether it's the new A constant or the old A constant, that's the recommended. And that's what I would do.
And then if you're finding that your surgeon's just consistently churning out at least +50, and then maybe just lightly suggest, hey, do you want to pull a lens that's maybe a quarter more myopic than you were going to use? I don't know.
Okay.
Just say the
Alright.
patients will be happier,
Okay.
better reading.
So you still want the patient to basically come out relatively close to Plano for both eyes after the surgery, and then you give them like the SA bump, just the way how you would do for the normal like LAL lens.
For sure. Yeah, don't change a thing with surgical targeting. I mean, the ultimate goal is to be Plano right out of the gate. You give them
Mhm.
those kind of 3 weeks of, they may be a little frustrated with the reading, but with the plus, they are most of the time relatively functional, at least computer stuff, like you said, Ken. That's what I'm experiencing. And then you give them the little bump, and oftentimes after lock or after LDD number 1, we can lock in if
Yeah.
they're happy with it. But
And
so yeah, don't change your normal way about going with the LAL.
and the plus is just going only in the non-dominant eye.
Bilateral.
Bilateral.
Yep.
Oh,
Yeah,
Bilateral.
has anybody played around? Because I know that's been tossed around, putting a regular LAL in the dominant and then a plus in the non. Just wondering if anyone started that.
I
We've
think the
done
only
it.
thing, have you done, Jess?
Yeah, okay. Go ahead, Nick.
No, go ahead. I'm curious.
We've had one patient that we've done it on, but that's just because LAL plus is a little more limited on its parameters and like what spherical powers they have. And so we had a patient who was outside the parameters in one eye for the LAL plus, but still within LAL. And that happened to be their dominant eye. So we put a standard LAL in their dominant eye and the LAL plus in the non-dominant eye because they've had a history of monovision too. And so we were planning on making that non-dominant eye like full monovision with the light adjustable lens. And that patient's currently in treatments right now and adjustments, and she's doing really well. So I think
Okay.
it's definitely possible she's not having any issues.
Yeah, that's a fair way. I think a fair strategy for sure, especially if the dominant eye is the LAL and the plus is the non-dominant eye. I would have no problem doing that. But you're right, it is kind of limited. The only reason we wouldn't use it again is if they're heavily apparated or if they just fall outside of the range. And there's a number of people that do. So I think it's 16 to 26 is the dioptric range of the LAL plus.
I do know they're working on trying to expand that, though, that we
Yes,
shouldn't be,
they are.
we should be getting that expanded range pretty soon, is my
I think
understanding.
it's cool. Dr. Guire is here, question and welcome. He's from Florida. So one of his surgeons is aiming for a +50 in the dominant eye and plano in the near. What do you guys think of that? Because the patients are loving their distance, but they want more near. So I'm thinking if you have him or her aim plano in both eyes, are going to be even happier.
Yeah, the only flip side of the coin, I guess, is using that as sort of a like kind of a sales tactic. Like this
I
is
know they
it's
really
working.
love that big wow factor.
Yeah, because
That's what
sometimes
I've
if
heard.
we do, I mean, if we end up with a hyperopic surprise and they're like +1 or something, those patients are super happy. However, they're super pissed for the first 3 weeks. So
Yeah.
take the good with the
Pretty
bad, but they're
frustrated
really
the first
excited
few
about it.
weeks.
Yeah. Yeah.
Yeah, like their first visit with you is like, I can't read anything, I can't see anything. It's like, that's okay, hold on, let me just do one little adjustment. Then they're
Yeah.
like, this is awesome. I get it.
Yeah, yeah, they're your best friends. A little magic, little pixie dust here, voila.
And then he also mentioned, sometimes are you worried if you're starting at plano at both that, and then you induce some reading that some of the distance might be compromised then a little bit? Or
I mean,
that they notice a bit like a bigger dip in their distance compared to before?
I'm usually annoyed with my surgeon when we do end up plano right out of the gate, like dead on, because
Yeah.
like it's perfect. And you still have to go through the treatments. We've
Yeah.
talked about this before. You have to go through the treatments because you have to get the macromers all activated.
Yeah.
And the only thing that's going to really happen is that their eyes are going to become dry.
Yeah.
So you still have to do that.
And
So,
the
yeah.
patients kind of get annoyed because they're like, well, why did I get this lens then? It like,
Mhm.
if you
Yeah.
didn't have to do it. And that's where I was like, I like it when they're a little plus because they
Yeah.
get the wow factor. They feel like they get their money's worth and everyone's winning.
I'll normally just be like, your surgeon nailed it. He knocked it out of the park.
Yeah.
Good.
It's a curse to having a great surgeon. Yeah.
Yeah.
So for someone like that, right? Like, and let's say they're like 2020 or even better, or like right out the gates. In terms of their first treatment, do you just do like a neutral treatment? So whatever their like refraction is, you just put that same number in the machine, or do you still kind of like target them for plano, even if they're like +2.5 -0.25?
I target plano no matter what. Yeah, even if they come out plano, I'll still do a plano target. Jenny, you've done different. Are you still doing that? Are you changing?
I just lock in, especially now that I know that, okay, yeah, you can induce some myopia. And then if it's really bad, then I know I can do a treatment before I do the second lock-in. That's how RxSight wants you to officially do a plano treatment, but I've been burned in the past doing that. So that's why I changed my protocol. My patients, I did it on 3 patients and every single one of them came back and they're like, it wasn't as good as before you did that treatment. So I'm like, well, so then I stopped and I haven't had that complaint since. So that's just me, but just for the record, RxSight technically wants you to do a plano. But if your patients are happy doing that, then keep, but I got tired of getting yelled at. So
I had one where I got burned doing that because I did that too, Jenny, for a while, and I would do a burn treatment into thin air just so I wasn't exposing the cornea to any UV, and then we go into the lock. Well, I had one patient who was, thank God, she was a really high near demand, and she ended up having a myopic shift in her right eye after the lock-in, confidently -50. Repeatable, I had her come back, I did everything you're supposed to do, and she was -50. And I talked to RxSight about it, and they informed me at the time that the treatment is apparently a part of the nomogram into the total number of macromers that pick up the entire lens. So I haven't done that since. This patient was really happy because she was a nurse. She does sutures. She didn't want to wear glasses up close. That was her primary thing. And so she's like, this is great. I can't see at a distance now as well, but this is great. Okay, cool. Perfect. That was my lesson. Yeah, she's happy. She was very happy. And I was like, okay, cool. I wasn't. And it was, it makes sense to me. So I don't do that anymore, but I see both sides.
Yeah.
So, well, guys, we're coming up on an hour here. Does anybody else have any questions? Or anybody else have any comments? I mean, we'll do another one of these. I definitely want to try to make these a little more regular. We had kind of a gap there with the holidays, and then I forgot that it was March.
Yeah,
all of a
this is
sudden.
grey because the
Yeah.
training wasn't much. And so
Yeah.
and my surgeon's not a lot of help because he doesn't do any of that. So
Yeah.
to hear from y'all, that's really good.
Awesome. We'll do again another one, maybe May, June. We'll do another. And Jenny and Jess, we didn't get to you guys' cases, so we'll save those.
Sounds
Hold
good.
on to them. But if anybody else has any cases too, I mean, this is supposed to be an open forum. It's not a lecture. It's a conversation. So I appreciate everybody's input. But if anybody else has anything they want to present, bring it to the table. Cool.
I
Thank
personally
you.
know that we should do this more often.
More often.
Oh, yeah. Once a
Okay.
month would be great.
Okay. Yeah, I'm sure we could. I would love to do more. Let's
Okay.
we'll do it. Just watch your emails. I've got everybody's address. We'll try to have an open line of communication, and we'll do more often.
Okay.
Thank you.
Thank
All right,
you
guys.
so much.
Thank
Have a
you.
good night. We'll see you.
Have a good night.
Take
Bye.
care.
Bye, everyone.
Bye.